Sensory evaluation. Under sensory evaluation, we have the superficial sensations, deep sensations, and cortical sensations. Under superficial, we make use of various stimulus and apply it across all the dermatomes over the body. To check for pain, we use pin prick. For light touch, cotton swab is used. For temperature, test tubes containing hot and cold water is used, and pressure can be applied using fingers. Under sensory evaluation, the second one is deep. Under deep, we have kinesthesia, proprioception, and vibration. So let's see the first one, which is kinesthesia, also called as joint position sense or awareness of movement. Initially, demonstrate to the patient with eyes open. This is done for the upper limb as well as lower limb. Later, demonstrate it with the patient's eyes closed. So the procedure is, hold the patient's finger or great toe and demonstrate up and down movements. That is, stabilize the proximal joint with one hand and move the finger up and down by holding distally, that is laterally, and do not touch the pulp of the finger. So the finger is moved up and down 7 times. The same procedure is demonstrated for the great toe. If the above procedure is not performed, you can use another method to assess kinesthesia. That is, with the patient's eyes closed, ask the patient to touch the nose with the forefingers, or with the arms outstretched, ask the patient to bring the forefingers together. The second one is proprioception. First, demonstrate the patient with the eyes open and then with eyes closed. The body limb or the arm is placed in a definite position by the therapist. Then the patient is asked to place the other limb in a similar position. The third one is vibration. A vibrating tuning fork is placed on the bony prominences. Start distally. If impaired, move proximally. For example, the radius, the patella, the medial malleolus, the head of the fibula, the anterior superior iliac spine. Ask the patient when the vibration starts and stops. The therapist counts the number of seconds. Significance of vibration: it helps in early detection of demyelinating disorders and peripheral neuropathy. Under cortical, we have stereognosis, tactile localization, 2-point discrimination, graphesthesia, recognition of texture, and baryognosis. So the first one is stereognosis. First demonstrate to the patient and then perform with eyes closed. The procedure is, ask the patient to identify objects of different shapes and sizes which are placed in the patient's hand. The next one is tactile localization. The therapist touches the subject at various regions on the limbs and asks the subject where it was touched. The next one is 2-point discrimination. 2-point discrimination is the ability to discriminate two blunt points when simultaneously applied to the patient's finger. Keep on decreasing the distance and note when the last 2 points were felt. With the distance decreasing, normally the patient should be able to identify a minimum distance of 5 mm or 0.5 cm on the upper limbs and 4 cm on the lower limbs. Then we have graphesthesia. Graphesthesia is the ability to recognize numbers, letters, or shapes which are traced out on the patient's palm. The next one is recognition of texture. Make use of velvet, silk material. The last one under cortical is baryognosis. Baryognosis is the ability to identify or differentiate the weight of different objects placed in the patient's hand. For example, the patient needs to identify which object is heavy and which one is light. You can get any one of the following responses for sensory evaluation. The first one is normal, which means the responses were intact. Inconsistent, sometimes the patient felt and sometimes they didn't. Inaccurate is, say for example, whenever you tested touch, the patient complained of pain. And the last one is exaggerated, which means absent or no response. Sensory motor link, or in other words, reflexes. So under reflexes, we have superficial reflexes, deep tendon reflexes, and the primitive reflexes. Under superficial reflexes, we have the abdominal reflex, the plantar reflex, cremasteric reflex, bulbocavernous reflex, anal reflex, Hoffman's sign, Wartenberg's sign. Under deep tendon reflexes, biceps, triceps, supinator, finger flexion, knee, and the ankle. Under primitive reflexes, we have the sucking or the rooting reflex, grasping reflex, glabella tap, and the palmomantle reflex. Grades of reflexes. Grade 0 is absent. Grade 1 diminished, which is facilitated by gender 6 maneuver. Grade 2 normal. Grade 3 brisk. Grade 4 clonus, which is involuntary oscillating stretch reflex due to upper motor neuron lesion. Where to check for clonus? So we have the patella clonus and the ankle clonus. For the patella clonus, the therapist performs a sudden sharp downward displacement of the patella. Patella clonus is seen in pyramidal lesions above L2 level. Under ankle clonus, the therapist sharply dorsiflexes the ankle with the leg relaxed. If oscillations persist, it means there is a pyramidal lesion above the S1 level. Gender 6 maneuver is performed to reinforce the tendon jerk as it increases the activity of the gamma efferent system. Few things to remember here. Physiology of the deep tendon reflexes. Tapping the tendon evokes a sharp muscular contraction in response to a stretch. In gender 6 maneuver, for the upper limb is done by clenching the teeth, and in the lower limb by pulling the flexed fingers against each other. Under superficial reflexes, the first one is the plantar reflex. Stroke the lateral aspect of the sole. Normally the response seen is flexion of the big toes and all the toes. If the response seen is fanning of small toes, dorsiflexion of the big toe, and flexion of the hip and knee, it is considered to be an extensor plantar response or the Babinski sign. This occurs due to contraction of the extensor hallucis longus, which is seen in upper motor neuron lesion. Chaddock's sign. Stroking distally over the lateral malleolus until the lateral border normally causes no movement, but in case of upper motor neuron lesion, you see extension of the great toe, which is similar to the Babinski reflex. However, in infants, the Babinski sign is considered normal. Abdominal reflex. Stroking over the abdomen, the response seen is contraction of the abdominal muscles. The next one is cremasteric reflex. This reflex is elicited by stroking the inner aspect of the thigh from above downwards with a blunt object. The response seen is contraction of the cremasteric muscle with elevation of testicle. The next one is Hoffman's sign. Here, the patient's hand is pronated. The therapist grasps the last phalanx of the middle finger on the lateral sides. With a sharp flick, the phalanx is passively flexed and suddenly released. If adduction and flexion of the thumb with flexion of the fingers is noticed, it means there is some corticospinal tract lesion. The bulbocavernous reflex. This reflex is elicited by pressing the glans penis. The response seen is contraction of the bulbocavernous muscle. The next one is anal reflex, which is elicited by stroking the skin on the mucous membrane in the perianal region. The response seen is contraction of the external anal sphincter. Then we have the Wartenberg sign. The patient's hand is supinated. The therapist pronates the hand and interlocks his fingers with the patient's. Now the patient pulls his finger away against the therapist's resistance. Normally the thumb extends. In case of pyramidal tract lesions, the thumb adducts and flexes. Under deep tendon reflexes, we have the biceps reflex, wherein the examiner's thumb is placed over the biceps tendon and then a blow is given over the biceps tendon. The response seen is elbow flexion. For triceps reflex, the patient's elbow is flexed and placed across the abdomen. Blow over the triceps tendon. The response seen is extension of the arm. Then we have the supinator reflex, which is done over the brachioradialis at the distal end of the radius with the hand in mid-prone position. The response seen is slight flexion of the forearm with supination. For finger flexion reflex, the therapist places the index finger over the palmar surface of the semi-flexed fingers. The response seen is flexion of the fingers and the thumb. Then we have knee jerk, wherein the patient's leg is resting over the therapist's arm and the therapist taps the patella tendon. The response seen is knee extension with quadriceps contraction. Ankle jerk. Externally rotate the patient's leg and hold the foot in slight dorsiflexion. Tap over the Achilles tendon. The response seen is contraction of the calf muscles with plantar flexion. Then we have the primitive reflexes. Under this, the first one is the sucking reflex. Gentle stroking of the center or the corner of the lips result in sucking or a rooting response. The second one is grasp reflex. Stroking in between the thumb and the index finger will cause grasping of finger. Stroking the back of the hand releases the grasp. Glabellar tap. Repeated tapping of the patient's glabella with the index finger normally produces 2 to 3 maximum blinks. If the blinking is continuous, it is considered to be abnormal, which is usually seen in Parkinson's and Alzheimer's disease. Lastly, we have the palmomental reflex. Stroking the palm causes ipsilateral contraction of the chin, that is the mentalis muscle.